Okay, good afternoon, everyone. It's a real pleasure for me to introduce Tom Purcell to you. Tom doesn't need an introduction because he interacts with so many of you in so many different situations, but he deserves an introduction. Tom is an associate professor of medicine who is in the oncology division. But equally importantly, he runs the oncology program for UC Health throughout the entire system. And in addition, serves as the chief medical officer at one of our new emerging hospitals, Highlands Ranch Hospital. Now, I do want to say that this relationship between the university and Highlands Ranch Hospital has to deal with a number of challenges. And in a very positive way, Tom is the perfect person to support us, to advocate for us, and to right-size our involvement in Highlands Ranch. And he's been doing that in a superb way. And I appreciate the partnership and the interactions that have emerged in this relationship, and I'm convinced that this is going to work out, and it's going to work out largely because of Tom. So Tom received his undergraduate degree from Millsap College, and I'm sure very few of you have heard of Millsap College. I never heard of Millsap College, but it's below the Mason-Dixon line, and he received his degree in chemistry and in physics, and graduated cum laude from Millsap. He also played football there. He then went on to the University of Chicago and received his MBA degree, and subsequent to that went to Emory for his MD degree, where he graduated Alpha Omega Alpha. After that, he went to UT Southwestern for his house staff training and excelled at that, and was a medical chief resident at UT Southwestern. Was recruited to Hopkins for his oncology training, and also excelled there in terms of the clinical practice of medicine and understanding how we could treat patients more effectively, and that led to thinking about alternative ways to treat patients with cancer. Now, you know, what's really fun to look at in Tom's CV is that everything that he has been involved in has focused on how do we treat patients more effectively that have cancer. How do we create the teams that are necessary to treat patients with cancer? And how do we address the families that are oftentimes involved in and affected by the individuals who have cancer? So please join me in welcoming Tom to the podium.
Okay. Thank you. Well, it's certainly a privilege for me to be here. I assume everybody can hear me in the back. I'm going to be talking today about exercise as cancer medicine, or is cancer medicine. And these are two of my loves, fitness and taking care of cancer patients. So I appreciate the opportunity. I have no conflicts of interest. And so today what I'd like for you to leave here with are three objectives. One, to understand some of the physiologic and metabolic adaptations to exercise that relates to cancer. Two, understand the evidence that we have and why we recommend cancer for patients, either exercise for everyone, but also for cancer patients. And then three, recognize as providers how important it is for us to recommend this to our patients. And so this, and a couple of things. First, email me if you want copies of these slides. And two, if you have a question, please interrupt me because I want to make sure to answer your questions and such. But this is kind of a framework of how I look at physical activity as it relates to the cancer continuum. The situation is such that there's primary prevention, preventing the initial cancer diagnosis, and then of course once the cancer diagnosis is made, then there are exercise and mechanisms around toleration of treatment, and then prevention of recurrence, and then if there is a recurrence, management of the quality of life. And what I won't be spending a ton of time today is, but what's revolutionizing what we're doing in exercise are the patient-related outcomes and the wearable devices. This is a lot about how we measure activity and such. My goal today is to show you what is the evidence around having activity and the success around cancer. So walking away from here, this is a cartoon that kind of shows the continuum, but what I'd hope that you take away from today is that whether in prevention, exercise is improving, whether at the initial diagnosis, exercise actually helps in the management of treatment and prevention of relapse, and even at the time of relapse, there are very significant positives to what exercise can do. And so here is my outline for today. I'm going to stick to this fairly closely, but there is a background, some things that I'll talk about, then the adaptations, and then what is the pathophysiology, or what is the mechanism of action of why exercise could help for cancer patients. Then I'll review the evidence, and then we'll talk about our cancer exercise program on this campus, Be Fit, Be Well. And so lifestyle impacts of cancer, if you were to add up the issues, and excluding, we know that smoking accounts for about 30% of all cancer deaths in the United States. But if you were to add up the other lifestyle impacts of excess body weight, physical activity, and an unhealthy diet, including alcohol, you would see that there's at least a 10 to 20% less likely to be diagnosed with cancer. And then if you were diagnosed with cancer, 20 to 30% less likely to die from it if we were to just have patients who would adhere to this. So the question is, who exercises in the United States? And certainly not her, but only 25% of Americans exercise. 50% or so are sedentary. So there's 25% of patients who do some exercise but don't meet the minimum requirements, which is listed here. Now, the other question is, who else exercises? And what I will tell you is that some of my training partners are right here in this room, and I'm telling you, that's the way to get it, Dr. Schwartz. That's awesome. So, but Dr. Schwartz is a smart man. Why is he exercising? Well, fitness matters. Fitness matters in health, obviously, and it will improve your risk as it relates to all-cause death. And this is old data from 2000, which shows that as we compare age groups, the fitter a person is, this is low, and I'll go through this in a little bit more detail, low exercisers or sedentary, moderate, and high. You can see as exercise persons who have a high fitness level have a lower risk of crude death rate. And so that's very important, particularly at any age. But what I'll point out to you is that even the moderate exercise group has a tremendous difference in this. So I'll kind of get to that. Now, you may say, maybe all of those patients are lean, mean, fighting machines like Dr. Schwartz and don't have any other medical problems. But what I will tell you, and this was a very elegant, comprehensive study published in 2002 by Stanford and a group at Stanford, which showed that regardless of other comorbidities, exercise is an independent, favorable component. And then you can see here, this is kind of the capability of performing exercise, whether it be, this is actually in a Bruce protocol, but 5 METs. 1 MET is just sitting and sitting quietly, and so as you increase your physical expenditure, the metabolic equivalents go up. And so you can see here the data, whether it be hypertension or lung disease or diabetes, those who were able to exercise at a high rate, a high fitness level, actually had a much lower relative risk of death, all cause. So very important. Now, okay, shifting, we know that fitness is important. What about cancer? Well, here's some of the data around cancer right now in 2018. USA has 1.7 million cases. In Colorado, we will have 25,000 or so diagnoses, and of course, 625,000 cancer deaths. What's exciting for us and exciting for healthcare in general is that we're having more and more cancer survivors. As you see here, by 2026, we will have 20 million cancer survivors. Now, from a death rate perspective, from a cancer death rate perspective, Colorado is the third lowest, and behind Utah and Hawaii. And we were talking with one of the chief residents. I'm from Mississippi, she's from Kentucky. And so those two states have the highest death rates from cancer. So a big deal. Now, let's transition to the adaptations of exercise just in the human body. So there's many different types of exercise, strength training, whether it be aerobic or anaerobic type training, sprinting or walking. And then something that many of you may be familiar with, high-intensity interval training or HIIT type training. Now, I'm not going to go through the biochemistry, but it's important because I'm going to mention this going forward. There are three energy systems involved in movement. We've studied this in biochem, but the phosphagen system, which is the sudden movement for 0 to 10 seconds. Then there's anaerobic type energy utilizing glucose, but forming lactate. And then there's oxidative phosphorylation associated with aerobic energy system. Now, when you look at adaptation, you first have to think about what happens to the human body when you don't exercise. So I'll talk a little bit about sarcopenia and then flip over to adaptation. So sarcopenia is defined as gradual muscle loss after the 4th decade of life, and it's really caused by inactivity. And it's really closely associated with the metabolic syndrome. And my workout partner and I were at the gym, and someone came up, and I think they were kidding, but they called us sarcopenic. And so we were both pretty unhappy about that. I was unhappy about that, David. But seriously, though, sarcopenia leads to serious, there's a cascade of effect. Whether a person is bed rest for other illnesses or sedentary lifestyle leads to a process of sarcopenia. And ultimately, adults, and particularly those who are 65 and older and 80 or older, will develop this type of muscle wasting. Now, the good news is that many times this is reversible. And so that's the good news. And so, but the skeletal muscle itself is one of the most important organs or tissues to help with homeostasis. And that may be why, and I'll allude to this, may be why when exercising and utilizing skeletal muscle may have other effects for cancer. So let's talk about adaptation. There are two types of adaptation, one of which is the changes during exercise. I'll talk about that a little later. And then chronic adaptation as it goes forward when you're regularly exercising. So here's a cartoon that kind of talks about chronic adaptation. We all know the cardiovascular effects of improvement and stabilization of hypertension and other vascular effects, but there are also autonomic type effects with decreasing sympathetic tone, increasing parasympathetic tone, and then of course some of the other non-cardiovascular effects related to skeletal muscle, lung function, and hematology. Now, some of the metabolic adaptations associated with cancer really relate to the mitochondria. And whether you are working aerobically, the aerobic energy system or anaerobic energy system, and you can see some things that occur over time. Both of these increase the number and size of mitochondria in skeletal muscle, which ultimately allows you to have better lactate clearance. Better lactate clearance means better fitness. And so there's metabolic adaptations are very, very important. And then something that we often see in the gym and in other places, the CNS really will adapt as well. And you can see here that, one of the most interesting things is to take a person who's sedentary and start exercising them, and over the first 6 to 9 weeks, their strength actually dramatically increases, much more disproportional to later on. And what's actually happening is not hypertrophy of the muscle. What's actually happening is better synchronization and increasing motor unit recruitment to allow the nervous system to be remodeled to a point to where you actually have a better contraction. So that's actually the neural adaptation. And we all know that the exercise improves brain function, and for depression and other types of illnesses is really important for the mental health. Now, there's a term, progressive overload. In exercise, as we all know, if you go in and do the same thing every day, your body's going to adapt to that. And so you have to progressively change and do different things to continue to challenge the body to get to grow. But there ultimately is a plateau. And then I found this steroids. I guess someone goes on performance-enhancing drugs, they can actually improve. But here's a study that's really interesting and encouraging for people like me who are getting older and older, that actually in both young and old patients, there is adaptation that can occur. And even people in their 80s can adapt to any type of exercise training, given their other comorbidities allow that. And this is a cartoon just to point out that resistance training or strength training really works on building hypertrophy and muscle mass. But that other type of training that I mentioned, high-intensity training, which takes into account the cardiovascular system and doing very intense but interval-type training, can lead to a variety of different things, including hypertrophy, protein synthesis and such, but also increasing the oxidative capacity with conditioning. Now, one final thing about adaptation in the mitochondria. A person who's taught me a lot about this is Inigo San Millan, who is a MD who's focused on a variety of things, performance, human performance, but he's taught me a lot about the mitochondria and how that is involved in dysfunction of the human body, including cancer. And there are many manuscripts that have been written regarding the association of mitochondrial dysfunction and cancer. And this was originally described, at least at a high level, by Dr. Warburg, who won the Nobel Prize in 1931, who pointed out that cancer, even in the presence of oxygen, will choose glycolysis and thus lactate formation. And so this concept of mitochondrial dysfunction occurs in cancer cells. And so does that have anything to do with the treatment of cancer? And I'll talk about that in a minute. Now, here's a sobering piece of data. If you are a trained individual and you take 3 weeks off, you lose almost 30% of your mitochondrial power, if you will. So it's recoverable. But you can see training is important to be consistent with. And so this type of deconditioning can occur. So let's talk about mechanism of action and how can we look at the mechanisms of how exercise could improve cancer outcomes. So now, back in 2008, this was outlined as kind of some of the physiologic reasons why maybe exercise improves cancer outcome. One is obviously insulin sensitivity and lack of insulin resistance. So you have lower levels of circulating insulin in comparison to, say, metabolic syndrome, where there's higher levels of insulin. That could be driving it. Or insulin like growth factor 1, which is elevated in that same type of situation. So here's a cartoon from that review, which kind of showed the opposite. If you have increased PO intake, decreased activity, driving obesity and insulin resistance, and how that ultimately can lead to an increase in insulin growth factor 1, which can have a cell survival and proliferation effect. But also in the direct secretion of insulin, remember C-peptide can be measured, and you can see these quartiles of patients. And the higher the C-peptide level, the overall increased risk for a patient, from risk in men for colorectal cancer. So that we know that there's something potentially related to that. Now, we all know that in postmenopausal women in particular, exercise can improve the level of endogenous estrogen and reduce that. And so the concept of reducing obesity, decreasing free estrogen can downregulate some of the estrogen-related cancers like breast and endometrial cancer. It's still a question about ovarian cancer. Then there's some other areas, whether it be having increased BMI and cancer risk, decreased physical activity, decreasing colorectal transit time, being on medicines that have been shown to downregulate polyps like NSAIDs, and then I alluded to the mitochondrial density. But this really doesn't get to what is going on in the tumor microenvironment. And so let's kind of take a look at a study. I'm just amazed with this. So this is a voluntary mouse wheel study where they took mice that had a control group and then mice that would be exposed to a wheel and would voluntarily run on it. And then after achieving a certain amount of fitness in those mice, injecting tumor cells and just watching and seeing what happens. And so that's that concept of what we're looking at here. And so this is a kind of a complicated slide, but let me walk you through it. First of all, the mice that were exercising were running 4 to 6 kilometers a day. That's pretty impressive. I was trying to equate that to length of leg and humans and how much that would be. But interestingly, they stratified. They stratified somewhat on gender, but also males compared to males and females compared to males didn't exactly do the same amount. So that's kind of like humans. But in general, a 4-week lead-in followed by an injection of cancer cells, and then they actually had a group that didn't do any more exercise and a group that started exercise. But the point is that no other treatment was given, but when you look at controls, and these are the lungs of the sacrifice control mice in comparison to the exercise group, both before and after, you can see a dramatic difference in the number and the amount of tumor. And so the question is, when they did all of this, they actually used several different cell lines, and again, albeit this is in mice, but showed just by having an exercise regimen, there was a 67% reduction in the growth of the cancer in comparison to the controls. There was no eradication of the tumors. So you can see what causes cancer is DNA damage, which ultimately causes mutations. So you can kind of imagine that there's something in the microenvironment that may be affecting that. And so let's kind of dig deeper. So in this study, the researchers knew that contracting muscle in the rat actually causes myokine release. And these are different signaling type molecules like IL-6, which we know a lot about, oncostatin, and SPARC. And the concept of having IL-6 released by the muscle with subsequent release from the adrenal gland of epinephrine attracted natural killer cells. And then subsequently, that natural killer cell process then triggered the other immune modulation. And there's some other types of myokine effects on breast cancer and colorectal cancer cells. But in general, what was seen is that in looking at the tumors, there were high levels of NK cells and cytotoxic T cells, and kind of an overall induction of the immune-related pathways. And it appeared that the natural killer cells are the spark, the immune spark that allow for that, the initial mobilization and redistribution into the tumor. Very interesting. So the authors discuss the fact that there are many intrinsic effects of exercise, including signaling and effects of blood flow, shear stress, reactive oxygen, sympathetic effects, and also the endocrine effects. But there's also just overall growth effect that seems to have, there was a clear reduction in growth rate and also a decrease in colony formation. When they took serum, they actually did some aside studies, took serum from exercise mice and actually bathed that in cancer cells. So this is kind of a summary cartoon that kind of points out that there's something much more going on in the tumor microenvironment, whether it be the acute exercise triggering some kind of immune modulation through natural killer cell inflammation or infiltration and such, versus kind of the chronic effects of being a trained individual, having better perfusion, better shear stress, reactive exposure to reactive oxygen species, and the sympathetic and endocrine effects. So that kind of leads us to what is the data. And so the data has been evolving over the last 15 years. We first noticed this in several key studies that I'll point out, but the fact is that most of the data that we have are associated with breast, colon, and prostate cancers, and we certainly need to evolve that for other cancers. So what is the evidence? And all the pictures I'm using are from our exercise program, and I'll kind of go through some specifics about that, but primary prevention. So this is kind of an interesting study. There's a lot of issues around the study, but the Cooper Institute in Dallas took 17,000 men who saw them in their clinic and with a median age of 50 and did a one-time treadmill test. So you show up, you do your treadmill test. And they looked at the ability, just like in those previous studies, the ability to, in your cardiovascular fitness. And so they stratified them on 5 different levels. And then they followed these men over the next 20 years. And so 2,800 or so were diagnosed with cancer, prostate, lung, and colorectal, and 769 died. Now, if you look at, when you pour through this study, there's a lot of issues just to note. Obviously, it's a very homogeneous population, and you can see here that the non-exercisers had a large current smoking percentage in comparison to quartile 5, which is the high exercisers had a much lower current smoke. But in general, what was shown is that men with high cardiorespiratory fitness, greater than 9 METs, had a 67% less chance of developing lung cancer and a 38% less chance of colorectal cancer. And that's kind of from a lung cancer, I'm a lung cancer doctor, I will tell you that patients who exercise most of the time don't smoke, so there's a confounding variable there. But in colorectal cancer, those are the numbers that we actually see. And so more was actually better. A 1 MET increase in your fitness was associated with a 14% relative risk reduction in cancer-specific mortality. Now, the same group actually did a study in women, and it was actually similar results. This was death rate from all-cause cancer. And you can see patients, and they stratified this based on body mass index, but regardless of what your body weight was, you had a much lower death rate if you were fit. So, talking about breast cancer, there have been numerous observational studies, and there is a reasonably clear pattern of lower rates among active women, in particular postmenopausal women, with a relative risk reduction of primary prevention of breast cancer of 0.7. So that's kind of known, and it leads to kind of the effects that I mentioned previously regarding the downregulation of endogenous estrogen. Now, this is from the Women's Health Initiative. 75,000 or so women again showed and this was MET hours per week, showed that there was a nice trend of, as people became more active, there was a less incidence of breast cancer being diagnosed. Now, the same kind of data has actually been done in colorectal cancer, where, and this is based on about 50 studies, that in general, people who are fitter, who are exercising, have a 30 to 40% lower risk of developing colorectal cancer. Now, there's two other cancers that have been talked about. I mentioned lung cancer. I won't go through that. There's a lot of compounding there. But uterine cancer being a cancer that is associated with estrogen and other sex hormones, uterine cancer has also been shown to be preventative with exercise. Now, this was a very interesting kind of pooled meta-analysis of 12 studies, epidemiological data from 12 prospective U.S. and European cohorts. This was published about 18 months ago, and interestingly showed up to 13 cancers seem to have a lower incidence when you compare high physical activity groups, so the highest activity, to the sedentary or lowest activity group. So a 20% reduction in 7 cancers and an absolute risk reduction overall, remember we said 10 to 20% for fitness, was 7%. So I think that in general, primary, it doesn't mean that patients, and all of us have dealt with this, doesn't mean that patients who are exercisers don't get cancer. In fact, that's certainly the case, but the relative risk is much lower. So let's talk about secondary prevention. So I mentioned breast, colon, and prostate was where the majority of the data is. This is a Nurses Health study which gave us tremendous data here where compared less than 3 MET hours per week, and you can actually see the benefit really hit at 9 or so as far as moderate activity, and kind of going forward. This actually slants up slightly. Hard to explain that. But the Nurses Health study really pointed that out. Now, you think, okay, if women exercise, they're going to have a less chance of recurring from their breast cancer, but what about the treatment of the breast cancer during that, what we call adjuvant treatment? And so this was a study, it's been updated several times, called the START trial, which actually randomized a control group versus resistance training versus aerobic training. And it took a group of patients and stratified them. And what was seen was there was definite improvement from the aerobic exercise as far as self-esteem, fitness, body fat. And interestingly, when you look at the control group, most of the control group became deconditioned. And those of us, if you've seen somebody go through chemo and are not exercising, they become weaker. They have a higher fat percentage, and so chemotherapy can really be tough on patients. But interestingly, the resistance training, so this is like strength training, actually showed that the chemotherapy completion rate was 8% better. Now, 8% is not 30%, but it was 8% better. And so what that pointed out was that something about the strength training and affecting skeletal muscle had something to do with the ability to tolerate treatment. Maybe that's not a magic bullet, but it had something to do with it. And so other kind of quality of life, fatigue, depression, anxiety, all of these were improved, but did not reach statistical significance. So and this was a study actually published about 2 years ago that kind of confirmed this. This is a different study from the same group that took this on-track group right here, is basically a high-intensity interval training. This is something that's become in vogue of doing home-type workouts, and then this is usual care, and this is all in breast cancer adjuvant treatment. And what it showed is that patients who required dose adjustments, meaning the treatment was too toxic for them for whatever reason, the group that was receiving the high-intensity training had the fewest amount of dose adjustments to their chemotherapy. And then the average change or percent dose reduction was similar in the two activity groups, whereas in the kind of usual care group was much higher. Now, we all know that chemotherapy, there is a certain concept called dose intensity. We want the chemotherapy dosing to be as high as possible. So what this has shown is that not only did we have fewer dose adjustments, when we did adjust them, it was much less than compared to the control. Again, leading to a better tolerance of treatment and potentially a better outcome in eradicating cancer cells, microscopic metastatic disease. A lot of people bring up the fact of lymphedema and exercising. This used to be a bigger issue when we weren't doing sentinel lymph node biopsies. Now that we're doing that, it's a much less issue. And what I will tell you is that weight training and lymphedema doesn't seem to be an issue. It actually can improve things. This was a smaller study, but it's reassuring, and this has been reconfirmed several times, that weight training by itself does not aggravate lymphedema in breast cancer patients. Now let's switch over to colorectal cancer. Again, secondary prevention. This was a large CALGB study, 89803, which did a great job of tracking physical activity in their patients, comparing that to a standard control group that did less than 3 METs per week. And you can see these are similar patients, whether they all got chemotherapy, all that kind of stuff, but the relative risk for recurrence dropped dramatically. So those who read the notes of the colorectal cancer patients that I see will know that I'm constantly harping patients on exercise, because this is real data. This is absolutely real data and as good as chemotherapy. Now, in that study, it was stratified for a variety of different areas, all of which showed that exercise actually improved the outcome. So there's been a couple of studies published recently that were meta-analysis that really kind of honed in on what the benefit is in breast cancer, colorectal cancer, and I haven't mentioned prostate cancer, but I will now, of the effect of exercise as far as mortality. And what this shows is across 26 studies of breast, colorectal, and prostate cancer patients, there's a 37% reduction in the risk of cancer-specific mortality. And then even when we look at recurrence and progression, kind of a similar grouping. And when you kind of see this kind of data of 60, relative risk of 0.65, this really is on balance with some of the major chemotherapy trials that have gotten FDA approval. And so the idea of fitness and exercise and implementing that post-diagnosis, incredibly important. Now I put a star here to remind me to tell you that I think this is the type of study that we should be doing here and will be evolving. This is a group of studies that were just summarized last month of lung cancer patients. Now, you talk to surgeons, they will tell you that fitter patients do better, less poor outcomes after surgery, less adverse events and such. And so these were 4 different, the numbers are not big, but 5 different studies, all of which were in lung cancer patients, which showed that exercise prior to surgery reduced post-op complications and improved outcome. And so I believe that not only in just overall whether cancer returns or not, recurrence prevention, secondary prevention, things like that, trying to do a better job of improving the morbidity of our treatments is very important. Now, we actually had a study here, Ryan Marker and I were working on this in pancreatic cancer patients, where we had a similar study of neoadjuvant chemotherapy and radiation patients that went through this. We had 5 patients that were able to go through that. So it was a study that didn't accrue a lot, but these are the types of studies that I believe will change how we approach cancer surgery and others. So there are many quality of life benefits. There are quality of life benefits that we're all familiar with for exercise. And so you can see here the side effects associated with cancer treatment and how exercise can benefit all of these different areas. So here's the conundrum that we're all facing. For greater than 70% of the population, there's an inability or unwillingness to meet the minimum physical activity guidelines. And so I just put this in here. You can lead a horse to water, Can't necessarily make them drink. I like this curve because it points out just if we can just take people a little bit from sedentary to moderate activity, look at the benefit that we think that we could get by moving these patients. And so the real question is, how do we do that? And as a person who runs an operational program, how do we engage people better in wanting to do the exercise that clearly has many benefits? So the one question I have is, do oncology providers recommend exercise? And you could ask this for do primary care providers recommend exercise? And this was a study, there's numerous other studies out there. 50% of oncology patients surveyed at the Mayo Clinic have discussed exercise with their oncologists. And no patient reported receiving more than general encouragement. Stay active. And so when I talk to patients and talk to them, okay, how fit are you? I'm really fit. You know, I walk around the house, go out and get the mail. You know, I'm fit. So people perceive exercise as usually sometimes their daily activity. So there's an education component as well. So exercise medicine or such is a prescription for exercise that is part of the treatment, part of the optimal treatment. Ideally driving endogenous, as we've talked about in the tumor microenvironment and others, hormonal and cytokine mediated processes within the body. So this is kind of, I've alluded to this, this is kind of what everyone should kind of look at and say, am I getting this or not? This is the general exercise prescription, 150 minutes per week of moderate intensity or 75 minutes per week of vigorous intensity. This is called rate of perceived exertion. And then, of course, a lot of people forget this, the resistance training, very important to activate the skeletal muscle. You can do that in a variety of ways. It's not something that you absolutely have to do barbell weights or things of that nature. A lot of different ways to do that, but very important to activate the skeletal muscle. But exercise itself is not a single medicine. Exercise is varied, and there's a lot of different types of exercise, and there's a lot of different situations that exercise could help or hurt a given situation. So just like with the understanding of the genetics of cancer and molecular biology and such, where it's moving toward a precision type delivery of care, exercise is moving toward a more precise way to define what is an appropriate regimen given the clinical situation. So what we tell patients if they're not exercising when we're diagnosed with cancer, to try to start ASAP. Now, Rome wasn't built in a day. We've seen a lot of people get hurt, and that's why we have our exercise program that I'll talk about in a second. People who have never exercised don't know how to exercise, and that's okay. We want to teach patients what the appropriate way to approach that. And then a tailored exercise medicine prescription is the best, and it kind of talks about these variety of different areas. Now, when we come up with specifics regarding our goals, usually we try to write down kind of what our goals are for a particular patient, and then based on the strategy that we have, then the frequency, duration, and intensity and the type of exercise itself will be outlined. But then we're getting to a point where this precision exercise component. So we have two major programs on campus here that address, for an oncology patient, exercise. So we have a robust oncology rehab program, which is conducted by a physical therapist within the hospital. I would tell you that, just in my experience, that about 20% of cancer patients at their diagnosis or such maybe not be able to exercise at all. And so they either due to impairments or other types of things. And so rehab is very important for that group of patients. But 80% or so can probably do more aggressive exercise. And so the BeFit Be Well program was started almost 5 years ago as a clinical program at the Anschutz Health and Wellness Center that provides specialized and supervised exercise to our patients. And we have a registry study that we've been running. This is our group, and they're sitting right over here. Do a great job. Nicole Klochek and her team do a fantastic job. And this is, for those of you, I love the teamwork, by the way. But we also have interns. We have interns that come in from all over the country, and they work for us over the summer or during the semester. And so this is the team. And really, when we think about Be Fit, Be Well, we really want to create a cancer exercise research laboratory. We have about 20 to 25 patients at any given time that go through the program. It's a 3-month program. And we're really interested in collaborating. There's some of our collaborators really want to collaborate with any of you who have an idea about how we could use an exercise prescription in some of your patients. So here's the program summary over the course of the last 4+ years. We've had 434 people enrolled. There's an attrition process, but 276 people completed a 3-month program. You can see here that we've had a wide variety of BMI come through the program. And from one of our publications that we had, we're making improvements just in a 3-month period, whether it be pulmonary function with VO2, grip strength, fatigue, and depression, all of which are statistically significant. So the future, and I'm ending, we've got about 10 minutes for questions. The future, what I see is a couple of different things. One is I do see us moving to a more precision type grouping. And whether that's grouped based on disease or based on clinical situation, utilizing the patient-reported outcomes and wearable devices, I really see that kind of coalescing to kind of get a better idea of how do we treat specific patients versus a one-size-fits-all approach. And what I would really love to do is take our research to another level, focusing on reducing morbidity as well as cost. Healthcare utilization in the cancer population is one of the biggest issues that healthcare finance has, and if there's any ways that we can implement, either in the bone marrow transplantation, which is kind of something that we've spoken about earlier with my group, or other categories of patients to reduce cost. If fitness would reduce costs, if patients were fitter and not utilize health care, that's going to be a win. So, and then finally, this is Becca and Nicole, and this beautiful lady is 88 years old. She's been in our program for 4+ years, and she has metastatic colon cancer, underwent surgery 4 years ago, and is still disease-free to this day. And even though that's an N of 1, I do think she's a perfect example of why this program exists. So I'll stop here. We've got 11 minutes for questions. Thank you very much.
Thanks, Tom. That was really great. I want to first ask whether there are questions from the trainees and fellows in the audience. Let me ask a provocative question. I spend a lot of time in the gym working out. You spend a lot of time in the gym working out. If we measure that time in the gym that we spend working out, how does that compare to the time that we end up accruing in terms of our longevity?
You know, that's a great, does anybody know the answer to that? Because it is a provocative question. I would say that it would more than...
What's the return on investment?
I would say the ROI is high, very high. You know, even if you get carried away in the gym, I would say if you're adding years to your life, you know, but it is interesting. I think there was just a study, New York Times in Circulation, I think this past week, that talked about intensity of exercise and how even 5 minutes walking up the stairs, doing something like that, actually is beneficial. And so I think, you know, the old school going in, cranking it out for 2 hours, kind of deal. There's a lot of hormonal type issues with that. Your cortisol level, if you train for a certain period of time, starts going up. It works against you. There's a lot of different endocrine issues. But I think with the wearable devices and such, we're going to find out just what that sweet spot is of fitness and the type of fitness.
Okay. Dr. Rush? Oh, okay, we have a question.
I'm Eric. I'm one of the R2s. In a way, I guess in our primary care clinics, we refer patients to physical therapy. Do you foresee, with more and more data coming out about the benefits of exercise, that we would be able to give our patients a prescription for a personal trainer to start programs like this?
I think that it's, and Ann Fulbrig is in the room here. So our Senior Associate Dean for Clinical Affairs, I do think that our ability to communicate this to payers is really important. We struggle. The program that we have for cancer patients costs per patient around $2,500 just in our cost, and patients pay about $150. So we are generously funded by a variety of different sources, but insurance don't pay a dime for that. So the idea of being able to write a prescription and then going, and are you kind of asking, would that be covered by insurance, or would it be just the ability to actually have a person at a fitness center be able to take that and run with it?
I think a lot of us in clinic, we tell our patients to exercise and we counsel them on what types of exercise are good, but then the issue is the access to that type of exercise. And we can refer patients to physical therapy if they need rehab, but it's much harder to get a patient to go to the gym and do things. If that was supervised, patients might have more success. So I didn't know with the data coming out, if you saw something in the future where that kind of culture could change, where we could give patients a prescription for a personal trainer, and then we would give a prescription for physical therapy.
Yeah. I think that it's all about the almighty dollar, unfortunately, in that situation. Who's going to pay for it? You know, so I think we need to get there for sure. Good question.
Dr. Rush?
Yes.
Yeah, so thank you so much for bringing this up and for showing across all disease states the benefit of fitness. I'm a diabetes doc, and study exercise. Couple questions. One was, in the data that you showed relative to survival, either in the people who had recurrence or after their first bout, it really looked like you needed a pretty robust exercise dose to see the good effect, which is different than across the general population. You know, where you see it just with a little bit of movement, your whole, like just getting out of the chair is already a really good thing. And so I'm wondering if you think there is something about the biology of how exercise impacts cancer that requires a little bit more of a movement off the mark to get that benefit.
Instead of like the cardiovascular fitness
so
or things that...
cardiovascular, which is just a very low level of METs per week, gets you a big benefit. And then the second comment related to the first set of questions is, if somebody has a diagnosis of prediabetes, you can get them coverage for physical activity training and into a diabetes prevention program, whereas when they have the diagnosis of diabetes, you can't. That's crazy.
It's crazy.
And cardiac rehab post-CABG or heart attack will be covered. Those are the only situations where I know it to be covered. My other question was, do you think that because of the cytokines, et cetera, in the cancer milieu, do you think that leads to accelerated deconditioning?
Yeah, so to answer your second question first, absolutely. Cancer cachexia and the other cytokine-mediated issues associated with cancer itself is going to cause that type of deconditioning, and really the difficulty, I mean, and when you've taken care of an athlete who has cancer, and it's really bad cancer, and they have progressive deconditioning despite effort and other things, I think there is something at the ground level that would be causing that above and beyond for cancer. To answer your first question, what is the sweet spot? I do think, I mean, when we see, it's moderate exercise, and so there has to be something about not necessarily overtly strenuous exercise, but something more than just general incremental movement that has to be driving this. And so I would say based on the data, but we may find that certain types of exercise have a higher benefit and could move that over certain types. So, you know, like we were talking about with high intensity training and things like that, but only for a short amount of time, you know, 5 or 10 minutes. So,
Dr. Holquin?
yeah.
Thank you. That's a great talk over here. You know, not everybody can exercise. Do you know if there is any benefit to alternative therapies such as, you know, stress relaxation, meditation? Has there been any comparative effectiveness research in this area?
It's a great question. I'm not aware of, you went to Southwestern, didn't you? Emory, that's where I remember. So I was at Emory too, so I remember, yes. I've been wanting to talk to you. But for some of the supportive care type things and the management of depression and anxiety and those types of things, there's clear benefit. In some of the physical symptoms of, say, neuropathy and things like that, acupuncture has been helpful. But I have not seen data regarding survival and prevention of disease recurrence. I haven't seen that related to supportive care.
Hi, right here. So if the data continues to move in the direction that all the things you've presented have, do you see this creating a fundamental change in medical education? Like doctors not only need to know, like, prescribe exercise, but like know a lot about all of the exercises that they're going to be prescribing?
I think so. I mean, I think, you know, one of my colleagues used to say, would you go to a dentist that had bad teeth? Or would you go to a financial counselor who was bankrupt? You know, so physicians, you know, kind of at some level, you don't have to train for an Ironman, but at some level have to walk the walk. And at some level, you have to be able to communicate some of these important data to patients. Where I think the challenge is, you know, everything in life is a bell curve, and there's going to be late adopters and no adopters. And how do you flip the switch in some of those? And I don't understand the psychology well enough to be able to say the right things in clinic to actually then allow the implementation of an exercise program.
Dr. Hill?
Tom, two short questions. One, there are people in the exercise physiology field pushing the concept of exercise deficiency syndrome. So what do you think of that? And second question, and you talked about this, all the great things that you're doing, exercise only works if you do it and if you keep doing it. So in your Be Fit, Be Well program, which is fantastic, how do you build in the long-term compliance, the behavioral science?
Okay. So the exercise deficient syndrome, I love that. I mean, because it clearly does create a syndrome of sedentary. I mean, you can just think of the sedentary type lifestyle my own father-in-law died of inactivity. He didn't have a chronic disease. He died of inactivity. And so I would agree with that. We struggle with having a 3-month program, and then it's almost like giving adjuvant chemotherapy and then patting somebody on the back and saying, you know, we'll see you in 6 months kind of deal, when it's been an intense process. I think we can improve on this. What we've tried to do is in the mode of exercises, and Nicole and Becca and Ian and the group, Jared, have done a great job of getting teams and groups of people to work. Most of the time, I do a much better job training if I'm training with another person. And so I find that if we have groups that create some accountability, maybe that can help. The understanding of what the actual magnitude of what you said, you have to continue to do this. It's not something that you can intermittently do. I think that education. So I totally agree with that. Thank you for asking that question.
Last question, Dr. Freed.
You talked about how we start declining at 30. Well, one thing that does decline in men as we age is testosterone. So does added testosterone add to the beneficial effects of exercise or remove benefit from exercise?
I don't know the exact answer to that question, but I will tell you that anecdotally, just in my experience, and I've dealt a lot with this, is that if the testosterone is abnormally low, then replacement to get to a normal range is beneficial. But the super therapeutic dosing of testosterone is an anabolic process, and I would not think that would, I think there are deleterious effects. The problem with testosterone is that it works. And that's why it's a performance-enhancing drug. That's why, but, you know, I have a family history of prostate cancer. There's no way that I'm going to ever even consider that unless I'm so subtherapeutic that maybe it would be appropriate. So I guess that's how I think of that.
Tom, thank you very much.
Yeah. Oh, yeah.
That was great.
Yeah. Thank you. Yeah. Oh, thank you.